What's going on, everybody? Welcome to another episode of the Core Consults RX podcast. And we got another episode coming at you that is ACPE accredited for continuing education purposes.
Yeah.
Thanks to our buddies over at freeCE.com. We are going to have this hour-long episode for you. Then you're going to hopefully learn something from it. Go take our 10-question multiple-choice exam, if you will, and pass it with flying colors. To access that exam, use the password HEART, H-E-A-R-T, all capital letters, and you will get access to the exam, pass that, and then you'll get your credit. So this is a service, obviously, through freeCE.com, and it's for the anyone who has unlimited membership access. So if you haven't upgraded your membership and you're just kind of going, monograph by monograph or live session by live session, definitely upgrade to the unlimited membership, and you'll get access to all of our podcast episodes that are accredited, and lots of other really good stuff. And then there's also, if you look in the show notes below, there'll be a discount code as well that you can use to get 15% off the purchase. So definitely check that out. And if you're already a member, like I said, HEART is the password, and that'll let you into the super fun exam.
Nice. Exam sounds kind of scary.
Yeah. Well,
like a quiz.
That's what we do here. We try to cause intimidation.
We're very intimidating.
Something like that. So, Cole, what are we talking about today?
Yeah, so turns out that there was a relatively recent, right?
April,
okay.
2022.
A couple months ago from when we're recording this, update to the heart failure guidelines, mainly related to HFrEF, reflecting a fair amount of things that we've been kind of referencing and talking about over the last, year and a half?
Yeah.
Probably a year and a half.
Something like that.
So we're gonna kind of take you through heart failure and hit the updates in the guidelines. I think this is going to be a great overview, kind of back to a few of the basics as well, related to cardiac output, peripheral vascular resistance, stuff like that, some of those formulas. And we're definitely going to hit the updates in the guidelines hard so you guys can be as up-to-date as possible.
Yes, and this is, I think we may have mentioned like the new classifications of heart failure in an episode, but this is where they are now official. And
yes.
So this is good. And they actually have a breakdown of treatment algorithms based on exactly those classifications.
And we'll say that these are the updated American guidelines. They differ in a few ways, actually, from the European guidelines. I was reading an article about it, interestingly. But the European guidelines aren't as gung-ho for some of the new therapies as the Americans are, interestingly.
Yeah.
But we will be talking about the U.S. guidelines.
So we'll start off with some basic, just background information. Hopefully this is all kind of review, but when we think about blood pressure as a whole, it's made up of, if you want to kind of simplify it down to, a math equation, if you will, blood pressure is equal to cardiac output times systemic vascular resistance, or you'll also see that called total peripheral resistance. And then cardiac output itself is a product of stroke volume multiplied by heart rate. And so you take that cardiac output multiplied by the systemic vascular resistance, that gives you your blood pressure. Now, stroke volume itself, it's part of that cardiac output, is basically the amount of blood that is pumped out of the heart with each beat, or at the end of diastole, and or at the beginning, rather, of the heartbeat, not the end. And that's important because the stroke volume is basically what is one of the major components for evaluating the ejection fraction, which is going to be important for kind of classifying heart failure. But if some other things that we have to take into account as far as our treatment kind of targets, when we talk about like preload, which is the stretching of the myocardial muscle fibers just prior to contraction, or the ventricular wall tension at the end of diastole is another way of looking at it. Afterload is the amount of aortic pressure that the heart ejects blood against in order to empty the left ventricle. And then contractility is the other term that's important, and that's going to be the basically something that accounts for the changes in the strength of myocardium contraction, independent of the preload and the afterload. So it's mediated by basically changes of the intracellular calcium concentration and inside the cardiomyocytes. So stroke volume itself, again, the amount of blood that's pumped out of the heart with each beat, is the one piece of ejection fraction, so the numerator, and that is going to be divided by the end diastolic volume, which then multiplied by the 100 to get turned into a percentage, and that will give you your ejection fraction, which is what we kind of use to evaluate where they're going to be classified in which stage, not stage, but which classification of heart failure the patient has.
Right. Because it's all in some way heart failure.
Right.
Just, classification. In short, ejection fraction measures how effectively your heart is pumping blood. So there are some major players in the development of heart failure as far as the pathophysiology goes. Many you'll be familiar with because they are sites of action of some of the drugs we'll talk about. So angiotensin 2 is one. It's initially a compensatory mechanism, but ultimately it's a negative. It increases with the increase in preload and afterload are definitely negative for MET. Aldosterone leads to sodium and fluid retention, which is characteristic frequently of heart failure. Vasopressin as well leads to fluid retention as well as vasoconstriction. We also have natriuretic peptides, A and B types. These are actually good. They're used to measure the severity or to assess the severity. Frequently, you'll see BNP levels to assess the severity of a patient's heart failure. But they're elevated in this instance, and they may actually have protective effects by decreasing preload.
So kind of looking at like the old school ways of classifying heart failure, we have our two big groups of ejection fraction or reduced ejection fraction heart failure and then preserved ejection fraction. And then even before that, reduced ejection fraction was considered systolic heart failure, and then preserved was diastolic heart failure. And basically the big difference is if you looking at the ventricle, the left ventricle, with reduced ejection fraction, you'll get this enlarged left ventricle that has a reduced ability to pump. And oftentimes you'll see that a very thinned and weakened wall of that ventricle, and it's basically allows more volume for the end diastolic volume. The problem is the ability to actually pump that blood out or give that stroke volume is reduced because of the lack of the pump or the droopy ventricle, if you will. And so the numerator of the ejection fraction equation is going down, whereas the denominator is actually increasing, and so that ejection fraction gets lower and lower. Now with preserved ejection fraction, that is where you're getting either a normal or a small left ventricle size, because the walls of the ventricle are actually thickening, and so it becomes like this very stiff muscle. But it has normal pumping capabilities. It's just much less room for that blood to kind of fill. And so usually you'll see preserved ejection fraction like in older patients and things like that, whereas reduced is usually after some sort of a cardiovascular event like an MI or something like that, that causes like actual cell death, and that's what causes that droopy ventricle to happen in the first place. The preserved is where it's more so causing hypertrophy over time, and just kind of takes up space in that ventricle with that thickened cell wall. So when the stroke volume will go down because there's not as much initial volume from the end diastolic, but that number is also going down. So when you do the math, the ejection fraction itself is preserved, if you will. But we have a few other classifications now. Yeah,
and I was going to say that we'll hit on the differences here, but we really had a great conversation about the subtleties of that with a guest a few months ago. It wasn't a cardiologist episode. We had a cardiologist on, and he framed it in a really a great way. So I'd encourage you, if you want more info on that, to go back and look at that episode.
We're going to have him back on. He was great.
Yeah, he's fantastic. Should have had him on today.
Yeah, missed opportunity.
What are we doing?
But you want to talk about the New York Heart Association?
So I think we're all probably pretty familiar with the older classifications from the New York Heart Association. I won't go into each of them too in depth, but there's basically stratified into 4 different groups. New York Heart Association Class 1, 2, 3, and 4, and it's progressively increasing the severity of a patient's heart failure. So in 1, they might have no limitation in physical activity, and it doesn't cause undue fatigue, palpitations, or dyspnea. Class 2, they might have slight limitations, but no issues at rest. 3, they might have marked limitation in physical activity, but comfortable at rest. And then 4, they would be unable to carry any physical activity without discomfort, and they're going to have symptoms at rest. And they also kind of have the 2 stratifications of HFpEF, heart failure with preserved ejection fraction, being greater than 50%, the ejection fraction being greater than 50%, and then the heart failure with reduced ejection fraction being less than 40%, leaving that no man's land of 40 to 50%, which we now have officially addressed in the newer guideline, right?
Yes, because that's been a point of debate for a while.
I know. It's been a big question.
How we actually treat those patients.
Sit there laying in my bed at night thinking, what are they classified as?
Yes.
Ejection fraction of 45, what are they?
We have all been there.
These are the existential questions
that Cole thinks about.
That you have in pharmacy school.
Oh, man. Yeah. And then for years after.
For years after.
Until, thank God, the American Heart Association came in and cleared it up for us so I can finally get some rest.
I know.
But last year, in April of 2021, there was a paper that was put out in the Journal of Cardiac Failure, and it was basically putting out this potential like universal definition and classifications of heart failure that proposed these revised stages of heart failure and then 4 classifications of ejection fraction. And we had brought it up, I think, a previous episode, but now these are what they have actually adopted. Mm-hmm. So to talk about the stages, there's stage A through D, and in stage A is basically patients that are at risk for heart failure, which means that they're at risk for heart failure, but they're not having any symptoms of heart failure. They're not having any kind of structural heart disease. There's no cardiac biomarkers of like stretch or injury, and it's something that the patient necessarily is not. It's kind of just the uncontrolled hypertension or things like that, diabetes, those types of things that would basically lead someone to this. So that put them at risk. Whereas stage B or pre-heart failure is where they don't necessarily have symptoms or signs of heart failure. However, there's evidence of one of the following. So it can either be structural heart disease, which is reduced left or right ventricular systolic function. It could be ventricular hypertrophy, wall motion abnormalities, valve heart disease, whatever, or evidence of increased filling pressures, which you'd have to get with either invasive hemodynamic measurements or non-invasive, like using a Doppler echocardiography. Or if a patient has increased, patients with risk factors in increased levels of BNP or some kind of like elevated troponins or something like that, without obviously presenting with any kind of acute coronary syndrome or MI, things like that. So if they have no symptoms or signs of heart failure, but they have evidence of one of those, they consider that pre-heart failure, which is
like pre-diabetes.
It's just like that, only with heart failure. And then stage C is what we actually think of when we talk about heart failure. That's like symptomatic heart failure. That's structural heart disease with current or previous symptoms of heart failure. And then D is just more advanced. So it's where the patient has very, very marked heart failure symptoms that interfere with daily life and has had hospitalizations despite attempts at optimizing evidence-based treatment, and potentially is going to be looking at either palliative care or cardiac transplant, something like that.
Got to tell you, I think they made the right choice going with the alphabetical classifications. I don't know why, but that just hits me better than the numeric.
Does it?
Yeah, I just like it better than 1, 2, 3, 4.
Well, there you go.
A, B, C, D.
You got Cole's nod of approval.
Pulmonary does that, right?
Yeah. For gold, for the COPD guidelines.
Yeah, they're alphabetical.
They sure are.
I can't think of anyone else who's numeric. I'm sure there's somebody.
Yeah, guaranteed there has to be.
There has to be. But none of like the big 3 diabetes stuff. Anyways, I digress.
Here nor there.
I digress. So when you're in that stage C and you have symptomatic heart failure, there's different, places you can be. So they kind of have some definitions for that. It's kind of on a spectrum. So if you're newly diagnosed, you're a new onset, they might call it de novo heart failure. This is a newly diagnosed patient. They don't have a previous history of heart failure. You can have patients who are on evidence-based treatment and their symptoms seem to resolve. And so they might call that resolution of symptoms. No more signs of heart failure. But since they were at that stage C with previous symptoms of heart failure, with persistent left ventricular dysfunction, you still want to keep them on treatment. So they should still be treated. heart failure in remission with resolution of previous structural and or functional heart disease is a possibility, and that would be classified under resolution of symptoms. Very uncommon for that to happen. So for the most part, these patients are going to continue on treatment in almost all cases. There's also persistent heart failure with ongoing symptoms, limited functional capacity. I think this is where the majority of patients lie. Their symptoms are persistent. They're on treatments, and we're hopefully delaying progression and improving outcomes. And then there's a worsening heart failure where a patient, even though they're on treatment, is seeing worsening symptoms, signs, functional capacity is worsening, and that's where you need to adjust their therapy to hopefully prevent them from going into stage D.
And then when it comes to the ejection fraction, so we obviously still have less than or 40% or less is going to be considered reduced ejection fraction like it always is. But now that middle ground, like Cole was talking about, where it's basically 41% to 49%, is going to be what they refer to as heart failure with mildly reduced ejection fraction, or HFMREF. MREF. But that is
Hef Mr. F.
Potentially that as well. Thank you, Cole. And then we have HFpEF, which is 50 and above. And they also have another one, which is called heart failure with improved ejection fraction, which is where it was previously less than 40%. However, on follow-up measurement after different medications and whatnot, that ejection fraction is now above 40%. Now, the reason why that's classified as something different is because what has happened in the past is patients will have an improvement in their ejection fraction, and then instead of following the same regimen that got them there, they'll be either like de-escalated or basically treated as if they have preserved ejection fraction, and then the end up kind of deteriorating back into reduced ejection fraction. So it was basically, yes, they've improved, but they want them to stay on the same treatment that got them there in the first place.
Right. So from there, like Mike said, if you're at less than 40 HFrEF, you can improve to HF improved or HFMREF. If you're at HFMREF, 41 to 49, you can decrease and progress to HFrEF.
Worsen.
It can worsen. It could get better and be over 50% and improve. They don't really have a classification for that since you were never actually at HFrEF. I think most people would probably still call this HF improved F, but it's not technically classified that way since they weren't ever.
There's literally a star in the guidelines of like, we don't really know how to guide patients here.
It's just like blank. But if you were always preserved, over 50%, you can of course worsen to HFMREF and then worsen to HFrEF as well. So I don't know. Just different ways to classify it, and hopefully would help guide therapy if you can classify appropriately.
Yeah. And we won't go through all the diagnostic algorithm, but they do have some really good kind of a flow chart in the guidelines, basically doing the clinical history, physical examination, EKG, various labs, looking at natriuretic peptides, so either a BMP or a NT-proBNP. And then the other thing is going to be the transthoracic echocardiogram, and then additional testing if necessary. But from there, that'll give you your ejection fraction, and you can kind of get them started on therapy based on whatever they'd be classified as.
Yep. You want to go ahead for therapy?
Let's start talking about some of these meds. So hopefully this is going to be some review.
Yes, this should be. We've been talking about a lot of the stuff, even the updates in the guidelines we have referenced before, but now that it's all official, it's good to have it reflected in the guidelines. So we'll start with the normal initial treatment that is kind of across the board for symptom management, and that's loop diuretics. They're used to decrease the fluid volume, make it easier for the heart to pump. They're typically used as needed in most cases, but could be scheduled just depending on the severity of the patient. They block sodium and chloride reabsorption in the thick ascending limb of the loop of Henle. They decrease sodium, potassium, chloride, magnesium, calcium, and water. So there's going to be a lot of stuff dragged out with the fluid that's coming. So you have to be aware of that. You want to be cautious not to over-diurese patients. Most of the loop diuretics, the oral ones, do contain a sulfa moiety. So you want to be cautious in a patient who has a true anaphylactic sulfa allergy. And they can also decrease blood pressure to a degree. So you want to be aware of that. They are Lasix, which is the most common that we're familiar with, furosemide, Bumex, bumetanide, Demodex, torsemide, And then there's one more that we've referenced before, but is not widely known, and that's ethacrynic acid. That's the one that does not have a sulfa moiety, and I think it's frequently more used in the hospital setting as opposed to the outpatient, right?
So I've only seen this one time, and I think a lot of even hospitals wouldn't pay for it unless you had a true sulfa allergy. I've personally only seen this one time, and it was a patient who literally had anaphylaxis to furosemide because of the sulfa moiety. So this wasn't like a person that has a Bactrim allergy, something like that. That's going to be more specific to Bactrim itself, whereas this was she's allergic to sulfur, and ethacrynic acid was the one we had to go with at that point. But I've only seen it one time, so it's probably something you'll never even run into, but it's one of those that it's important to know because that one time you need it, it's good to have.
Right. Something to have in your toolbox.
Max dose, just to kind of throw this out there, but furosemide is usually a max dose of 600 milligrams per day. Bumetanide is 10 milligrams per day. Torsemide 200, and then ethacrynic acid is 400 per day. So just to kind of throw those. But if we want like a conversion, if you're thinking about oral therapies, furosemide 40 equals 1 milligram of bumetanide equals 20 milligrams of torsemide equals 50 milligrams of ethacrynic acid. And then all of these are going to be kind of a 1-to-1 ratio from an IV to PO, except for furosemide, that's usually considered a 1-to-2 ratio.
Yeah, and that comes up a lot.
Yeah.
For exacerbations and things like that.
Yeah, exactly. And then the other diuretic that you will see utilized in heart failure is a specific thiazide diuretic, although technically speaking they say you can use other thiazides, but this is the one that you really only see used in this particular case, and it's Metolazone. And this is used for patients who are basically kind of maxed out or plateaued on their loop diuretic to give a synergistic diuretic effect when you add this to it. So Metolazone is a thiazide diuretic, but mechanistically it works in the distal convoluted tubule like most thiazides do, but it also has activity at the proximal convoluted tubule. So I guess the thought is that it can absorb or block the reabsorption of certain electrolytes, and the proximal convoluted tubule, which pushes more electrolytes into the loop of Henle and allows the loop diuretic to work a little bit better. The key to this, though, is that because Metolazone is an oral agent, and a lot of times, especially in the hospital setting where this would be done, the patient is on an IV loop diuretic. You would give the Metolazone 30 minutes prior to actually giving the IV loop diuretic. Otherwise, the loop's going to get there way before the Metolazone does because of first pass metabolism, taking it orally, and it's going to take it's not really going to have time to do its thing. So give the Metolazone first, wait about 30 minutes, then make sure you give the loop. Yeah. But yeah, this is something you can really diurese someone, so you got to be really careful with that.
And in the outpatient setting, you'll hear the doctors will usually tell a patient it's like their booster or something.
Yeah.
They'll call furosemide their water pill, and they might call this their booster. So.
I've even seen patients that take it like 2 days out of the 7.
Yeah.
And just to kind of a couple days a week give you a little bit of a boost.
Yeah, I feel like I see that a lot more than, I don't know that I ever saw them taking it like with every dose.
Yeah, you will probably.
Over diuresis.
Yeah.
Just a couple other notes that they do have different mechanism, or they do have different links of action. So bumetanide and furosemide can be once or twice a day. Torsemide has a longer half-life, so it would just be once a day, as well as Metolazone. It would only be given once a day. That's kind of a mainstay as far as symptom management. The mainstays as far as first line with good evidence for mortality, heart failure, hospitalization reduction is going to be the ACEs and Arbs, but more importantly, the ARNIs, if we're thinking about the guidelines. So we have a number of them, a whole bunch of ACEs. Most commonly, we see lisinopril, enalapril, on occasion, maybe ramipril or quinapril. But there's a number of others that are less common. Arbs, we have candesartan, losartan, and valsartan. And then we also have the ARNIs, which are the angiotensin receptor and neprilysin inhibitors. We only have one. This is the newest class that we're all probably familiar with at this point. I feel like it's been 4 or 5, maybe even 6 years.
Oh, it came out, I think, like right as I graduated. So 2015.
Yeah, 7 years. Gosh.
Way
I remember
back.
when this was New Kid on the Block, man.
AJ.
That's when you know you've been
I'm
out for a
so
while.
young, AJ. Don't you dare.
But yeah, so just to touch on what it is, so it's got an angiotensin receptor blocker in there, like an ARB plus a neprilysin inhibitor. Neprilysin is an enzyme that is responsible for breaking down several vasodilatory peptides like natriuretic peptide, bradykinin, etc. So by blocking neprilysin, we're going to promote vasodilation by promoting those vasodilatory peptides. So that's kind of how it acts synergistically. It's a unique type of molecule as well. The drugs are sacubitril and valsartan specifically, branded as Entresto. It does have some contraindications, as you can imagine. It would be a duplication really to use it with an ACE or an ARB, so they cannot be used together. And a history of angioedema is technically a contraindication to Entresto, even though the ARB is what's in there, which is a little lower risk.
The neprilysin is really the big
right.
the angioedema risk,
right?
Because it blocks that's normally responsible for breaking down bradykinin, which just like with the ACE would allow that to build up. So
right.
Even though we don't really think about that with an ARB, whoops.
In combination.
Yeah.
Yes. So not only is it contraindicated with that history, be aware of that as a possible side effect used as monotherapy, or used by itself, I should say. Also, renal impairment, use caution, hyperkalemia, hypotension, and then it can have a cough, a dry cough for the similar reasons with the bradykinin, kind of like an ACE. In a patient who has been on an ACE or an ARB, I believe, as well.
No, just ACE now.
Just an ACE? Mm-hmm. Okay. There must be a 36-hour washout period from stopping the ACE and starting Entresto. So if you're on an ARB, you can start the next day. Mm-hmm. Oh, okay, cool. And I think based on the label, they want you to have been on one previously, but that's frequently not done, right?
Yeah.
I
mean,
so looking at the guidelines, they don't say that. I think it's just the way it was studied in Paradigm.
Yeah, exactly. And I think it's one of those things that by the time they get to the stage, they're probably going to be on an ACE or ARB anyway. But yeah, the 36-hour
going
is pretty important.
In the future, I mean, even now, I mean, it's used pretty ubiquitously now, but in the future, there probably will be a lot of people who maybe have never newly diagnosed who did not try an ACE or ARB who are going to be started on it. But it's important to note that because of how it acts and how the neprilysin inhibitor acts, the BNP will not be accurate. So frequently, they might measure an NT pro BNP instead to get a more accurate reading.
But like Cole mentioned, the Paradigm HF trial, that's the kind of the first big landmark trial we had with Entresto, and it was compared head-to-head with enalapril. And it was looked at, that first study was done in patients that had reduced ejection fraction heart failure. And the primary outcome they were looking for was basically the cardiovascular mortality or the heart failure hospitalization, so the composite of that. And it was statistically significant reduction in those events with Entresto with a number needed to treat of 21. They also showed cardiovascular mortality with a number needed to treat of 31. Hospitalizations by itself was a number needed to treat of 36. And then you did get a little bit more reduction in blood pressure with an ARNI. And then again, like Cole was saying, that side effect risk we're all seeing, which is what we kind of expected. But the outcomes were definitely superior with Entresto versus enalapril.
Yeah, it's pretty stark. And I mean, the only thing keeping it from being like the true first line and not just punched in there which it is. They still say they prefer that. And this guideline, I should say, does make it more clear that you should always
try to get them on this
pretty much no matter what, unless you just cannot use an ACE or ARB. If you cannot use an ARNI, they kind of made them in the previous one, made them kind of on the same level because of the cost. But now it's they definitely prefer it.
Right. The cost is still obviously a factor, but it's easier, and there are some good patient assistance programs and whatnot. Yeah. But if you do have to have them on an ACE inhibitor or an ARB for that matter, the other thing that's important, this is going to be something that is talked about throughout all these drug classes, but we do have typically target doses that we want to push patients to, specifically in heart failure. It's not like with hypertension where we're just trying to treat to their goal blood pressure. Right. Heart failure has very specific studied target doses that have been shown to reduce mortality. One example of this is the Atlas trial, which looked at patients taking lisinopril 5 versus 35 milligrams. And I mean, these weren't patients that had necessarily needed a reduction in blood pressure. However, when you looked at the end of the study, there was a 12% lower risk of hospitalization or death for any reason. And then hospitalizations by itself was a 24% reduction with the higher dose of lisinopril, even though they didn't necessarily, from a blood pressure standpoint, need to go to a higher dose.
Right.
If you can't achieve that maximally, targeted dose, then we just whatever you can get the patient up to that they can tolerate.
Right. And you can make some strategic decisions based on what might decrease blood pressure more than others, and we'll talk about that as we go, to try to get it to where they can tolerate those goal doses. Right? So if a person has a history of angioedema, because this is important with these drugs, on an ACE, they can't have an ARNI, but can they have an ARB? So this is a long-asked question. We do have some data to guide us. So there's the CHARM trials. The CHARM alternative trial in particular included patients that could not tolerate an ACE inhibitor. It was candesartan 32 milligrams versus placebo, and 39 of the patients in the treatment group did have a history of angioedema, and they did okay. And it reduced the risk of cardiovascular death and hospitalization. So, I think... I don't know. I'm generally more cautious than Mike, but I guess the answer would be yes, you can.
So the guidelines do say to go ahead and do it, even if the reason they couldn't tolerate an ACE was angioedema.
Yeah.
And it was pretty funny. We actually had this come up at our clinic not too long ago, and the patient had a history of angioedema, and they were going to stop, the ACE and then not do an ARB, and the person had HFrEF, and we started to kind of all talk about it as a group, and the person who was seeing the patient, one of the provider that was dealing with it, was saying, I'm just not really comfortable with this, and one of our new internal medicine docs, he said, I'm comfortable with it. I'll prescribe it. And he goes, I've done this so many times in my residency and given an R because I've never had any issues with it.
It's good.
So yeah, and the person did fine.
Yeah.
So it is one of those things, like Cole said, it can be a little bit like, ugh.
It's like when you see an anaphylactic allergy. It's like you just get nervous about it.
Yeah.
But
and I feel like it's something that's like before was, really frowned upon, and like we kind of were taught, the ACE cough, and you just learn those side effects as if they're the same from an ACE and an ARB standpoint, but it's not true.
No, yeah. We learned them to be effectively the same drugs, but they do work differently.
Different targets. You're missing that bradykinin breakdown with the ARB.
Yep.
You're still getting that, or so you're still getting the breakdown
with the ARB.
Yeah.
Yep.
All right, so that's the first important class of medications. The next one is going to be beta blockers. So unlike with hypertension, where you hear us hating on beta blockers and saying they're fifth or sixth line, in heart failure, especially HFrEF, they are definitely like first line.
Tied for first line.
Yes. But that being said, there are only 3 that they actually recommend in the guidelines because of the outcome data that's available. So we have bisoprolol, which was seen to reduce mortality in the CBIS-2 trial. We have metoprolol succinate, not tartrate, but succinate in the MERIT-HF trial, and carvedilol was seen in the Copernicus trial. And the doses for those, the target doses that have been actually shown to reduce mortality, 10 milligrams of bisoprolol, 200 milligrams of metoprolol succinate, and then 25 milligrams of carvedilol twice a day. You can go up to 50 milligrams twice a day if a patient weighs more than 85 kilograms. Yeah. The one thing that the guidelines do mention, but it's not based on actual data, is Coreg CR, or carvedilol extended release. So I thought that was kind of interesting that they did mention those, whereas metoprolol, they're very specific about using succinate.
Yeah,
but
CR wasn't studied.
Yeah, it wasn't studied, but they do mention it in the guidelines as like a possibility. So I kind of take that with a grain of salt because it doesn't have the data behind. I'm sure it's fine.
I guess the thought is that metoprolol succinate versus tartrate is long acting versus short, and then maybe carvedilol.
So are these.
We have the short acting that has the data.
Oh yeah.
And so maybe like making a longer acting will make a difference. Maybe that's I don't know.
Maybe that's their thought. Well, plus metoprolol tartrate was compared to carvedilol and shown to be inferior. So
yes.
That's it's debatable. Anyways, let's just say though, you're like, hey, I want to go ahead and do carvedilol CR because the person will only take something once a day, and I just want to get them on carvedilol. So what are you going to do? You would pull out your app that's from today's sponsor and our main sponsor, Pearls. So if you have not checked out pearls.com, pyrls.com/CoreConsultRx, definitely check their website out, sign up for a free account, and you can then pull up their app and then look at the carvedilol IR to CR conversion that's available. And so, for example, 6.25 milligrams twice a day, or total, which would be 3.125 milligrams twice a day, is equal to 10 milligrams once a day of the CR. 12.5 milligrams a day of the immediate release is equal to 20 milligrams daily with the CR. And if you're wondering, like, why do we need more of a higher dose with the once a day controlled release? That's because it's going to go through first pass metabolism at a much slower rate. So 2D6 is going to be chomping it up, and it's going to take more of a starting dose to get the same bioavailability as the immediate release. So that way you don't have to memorize it. You can just use your Pearls app. So if you haven't checked them out, definitely give them a look, and you can get a free membership through them and see if you like it before you upgrade. But I definitely think you'll enjoy the app. So check that out in the show notes, and we appreciate Pearls for the sponsorship.
Love it. Love that app. So a couple more things about beta blockers. So an important counseling point, important thing to know as you're initiating is to start low and go slow. Couple of reasons for that. If you think about symptoms of heart failure, we didn't go into a whole lot of it, but dyspnea on exertion, fatigue, that sort of thing. Taking a beta blocker, dyspnea on, if you're exercising, taking a beta blocker can cause some of the same types of symptoms, right? Because it's going to keep your heart rate low, and it might cause some, exercise intolerance is what I'm looking for, that sort of thing. So if a patient is maybe had a recent exacerbation or they're fluid overloaded, you really don't want to start a beta blocker yet. You want to wait till they're euvolemic or they're post-exacerbation. They're not in that phase to initiate a beta blocker. And increasing it too fast can cause an exacerbation of symptoms as well. So once you get it started, you want to start low, go slow, but you're still going towards the goal doses that have been studied, regardless of what their blood pressure is or whatever. So as far as they can tolerate it, you want to get them to those goal doses. And Mike referenced that carvedilol had been put up against metoprolol tartrate and was superior. So that was the COMET trial. Carvedilol 25 twice a day plus metoprolol tartrate, or versus metoprolol tartrate 50 milligrams twice a day. Carvedilol was better, decrease in all-cause mortality with carvedilol by a 6-month time frame. And the question is, can the results be,
extrapolated?
Right, extrapolated.
So as far as is carvedilol better than metoprolol succinate?
Right.
Which we don't know. But the way I look at it is, if I need to pick between those three, if there's nothing else guiding it, it doesn't really matter. I typically go with carvedilol. But really, the way I kind of break it down is, do I need further blood pressure lowering for this patient? And if I do, I'm going to use carvedilol because it's an alpha and beta blocker. So we're going to block not only cardiac output, but we're also going to block the systemic vascular resistance on the alpha side. And so we should get lower blood pressure all around. If I do not need lower blood pressure, then I can go with bisoprolol or metoprolol, which are only going to block the beta receptors, so that systemic vascular resistance is going to stay the same or even potentially go up, because it's going to offset that cardiac output decrease. Now, one that's interesting is, what if the patient has heart failure and COPD? And the recommended beta blocker in this case is actually bisoprolol. And the reason for that is because although metoprolol and bisoprolol are both considered cardioselective, metoprolol is about 4 times as cardioselective as non-selective, but bisoprolol is 14 times more selective. So there's going to be almost no impact on the beta receptors in the lungs. And so, the patient's albuterol or Combivent or whatever they're using for the rescue inhaler for their COPD or their LABA is going to be able to still bind effectively and not be interacted with that beta blocker. They've actually studied that and compared all 3 of them together.
That's very interesting.
I thought so.
Yes. Well, that's why I included it, right? Yeah. So the last class, or the previous last class that you would kind of automatically add on as an evidence-based treatment before this updated guideline, or at least before we had some of the data from the last couple of years, would be aldosterone receptor antagonists. So we have spironolactone and eplerenone. They compete with aldosterone at the receptor sites in the distal convoluted tubule and collecting duct. They reduce sodium and water retention, cardiac remodeling, and risk of sudden death. So the trial that showed spironolactone's benefit is the RAILS trial. They included patients with an ejection fraction below 35%. The patients were on standard evidence-based therapy with an ACE or a beta blocker, etc. And they did decrease all-cause mortality and hospitalization. Eplerenone can also be included in there and had similar results in the Emphasis HF trial. The number needed to treat to prevent 1 cardiovascular death or heart failure hospitalization in 1 year was only 19. It's a major CYP3A4 substrate, but there are some limitations as far as the fact that it can definitely cause hyperkalemia, or it can cause a bump in potassium. It can also cause a bump in serum creatinine. So if a patient has elevated baseline potassium or serum creatinine, you don't want to use it. The numbers there are potassium greater than 5, a serum creatinine greater than 2 in females, or greater than 2.5 in males. And also if they have poor kidney function, if their creatinine clearance is less than 30 mils per minute, another marker along with serum creatinine, then you would not want to initiate them at that point either.
All right. So moving right along to a class of medications that I think we're all familiar with and have been getting a lot of press lately, the Sglt2 inhibitors. So these are a class of medications that were initially a anti-diabetic medication for glucose management. They work in the proximal convoluted tubule to basically decrease the glucose reabsorption and flush more glucose out to the urine. And because of that, they have this diuretic and natriuresis effect that is associated with decreases in plasma volume, blood pressure, vascular stiffness, preload and afterload, as well as that cardiac wall stress. And so they started looking at cardiovascular outcomes in patients with diabetes that also were on these meds. And they noticed that they were getting a reduction in heart failure hospitalizations when they were put on these medications. And so the dapagliflozin and empagliflozin are the two that have done further studies in patients who have heart failure and seen their effects. And these were studies that were done in patients that had diabetes or didn't have diabetes, because you can take you don't have to have diabetes as a comorbidity.
Right.
And in fact, they will lower the glucose threshold for glucose reabsorption before you start spilling glucose in the urine, but it's still enough glucose so that you will not go low. And so a patient without diabetes, taking this is not like severe risk for hypoglycemia or anything
low
like
risk.
that. It's there, but it's low. But dapagliflozin, for example, was looked at in the DAPA-HF trial, and they showed that there was a reduction in hospitalizations for heart failure as well as cardiovascular mortality. And then the empagliflozin study was the Emperor-reduced study, and they actually have one for Preserve now as well, the Emperor-Preserve study that showed a decrease in hospitalizations. The primary composite was statistically different, but it was more so being kind of led by the hospitalization risk reduction.
Right.
So empagliflozin and dapagliflozin are two that now the guidelines recommend as first-line options for patients with heart failure. And they're also going to be an important class when we talk about pre-heart failure, because they're actually some of the go-tos for that as well.
Yes.
There was you want to talk about the other?
No, you got it.
They also was another one that was being looked at that's called sotagliflozin, and it's a SGLT1 and 2 inhibitor, so a dual inhibitor. And this one kind of looked promising, but they showed a statistical reduction in the primary composite, which included hospitalizations and death. But the problem, again, it was being driven by hospitalizations. The death by its secondary outcome by itself was not statistically reduced. So I don't know if this is going to be one that they really push hard for, but it was the Soloist WHF trial, if you want to take a look at that. And also there's a group called Cardio Nerds online that has some really good like infographics, and I think they have a podcast as well. So check them out if you want to see like kind of a breakdown of some of these studies. They have some really good infographics and quick one-sliders that'll tell you all the info. They're a good group. I don't know them personally, but they seem cool.
I mean, if they got nerd in their name, they got to be good.
They got to be.
So that was kind of probably the biggest update to the guidelines that reflected the kind of more recent evidence. So now we have, 4 classes that we're automatically basically starting all patients that can tolerate them on, an ACE, ARB, or ARNI for one, beta blockers, aldosterone antagonists, and then SGLT2 inhibitors, 4. But we have some others, another that has some reasonable evidence in a certain patient population. So there's Bidil, hydralazine isosorbide dinitrate. Hydralazine is a direct arterial vasodilator. It decreases afterload. Hydralazine also decreases the development of nitrate tachyphylaxis, which is kind of like a tolerance that patients get to taking nitrates over time. And so that's why it's combined with isosorbide dinitrate. They increase the availability of nitric oxide, which cause venous vasodilation and a decrease in preload. They can't be used in patients with coronary artery disease, and they have some side effects associated with them: headache, reflex tachycardia, palpitations, fluid retention in some cases. And they are contraindicated with PDE5 inhibitors like all nitrates are. Isosorbide mononitrate is also available, and you'll see that used maybe separately along with hydralazine in many cases for cost purposes, but it is not included in the heart failure guidelines.
Now, the interesting thing is this was actually not shown to be an effective option at reducing mortality risk in the VHF trial that was done. And there was a follow-up trial, though, that was called AHEFT, and it included African-American patients that had heart failure with an ejection fraction less than 35%. And these patients were on ACEs, Arbs, beta blockers, diuretics, and then when they added on Bidil, it reduced mortality, all-cause mortality with a number needed to treat of 25, and then hospitalizations, number needed to treat of 13. It was stopped early because the benefit was seen so early, but we tend to think of this as being a potential add-on for our African-American patients. Although if the patient couldn't be on an ACE or ARB, then this sometimes will be extrapolated. That data will be extrapolated, and they'll just use this as another at least potential option, but we just don't have the same outcome data.
Right, but it could also be added on.
Yeah. It can be.
Could be also added on. We have a couple other options as well with not as fantastic of data. There's ibabardine, branded as Corlanor. It causes hyperpolarization activated cyclic nucleotide gated channel blocker, or it is one of those, an HCN blocker. It has some specific parameters that could prevent you from using it. It's contraindicated with a low heart rate of less than 70. The target heart rate when you're taking it resting is 50 to 60 beats per minute, I believe. And it does have some adverse effects related to that: bradycardia, increase in blood pressure, possible AFib, that sort of thing. It was looked at in the SHIFT trial, patients with HFrEF who were on maximally tolerated guideline-directed therapy. Primary outcome was a composite of heart failure, hospitalization, or death. It significantly decreased the hospitalizations, but if you extrapolated to the all-cause mortality, it did not significantly decrease that.
No, it was decreasing hospitalizations, but not death.
Yeah, isn't that what I said?
Maybe I misunderstood you.
If I didn't, decrease hospitalizations, but not mortality benefit, like we have with the other initial 4 and sometimes 5 option. But with this, it did not have mortality data. So you won't really see this used too often, maybe in a severe refractory patient, but it's indicated in patients with an ejection fraction less than 35, heart rate greater than 70, and they should be on maximally tolerated beta blockers or have a contraindication to beta blocker use as well.
And then the last drug that is fairly new is vericiguat, guanylate cyclase stimulator. This is similar mechanism to like vericiguat that we use for, or riociguat rather, that we use in pulmonary arterial hypertension. But this drug, again, was a new novel mechanism for heart failure, and unfortunately, the outcomes started to look promising, but it was statistically significant that for the primary outcome, but it was being driven by hospitalizations, not the cardiovascular death. So we did not prolong life, but we did reduce hospitalizations. So the way to kind of think about the use of Corlanor and or ibabardine or vericiguat is basically thinking along the lines of, if you have them on optimal first-line therapy and they're still having hospitalizations due to heart failure, then maybe we can add these on to keep them out of the hospital and increase quality of life. But they need to be optimized on first-line options first, right, ideally. There's
one more option that you'll see pop up, probably mostly in patients who've been on it for a long time as opposed to newly initiated patients, but Digoxin, old drug that we're familiar with, it might fall into that same category, but still would probably be like one of the last things that you would use. Mm-hmm. But ultimately, it in the DITCH trial did not show survival benefit either, only some reductions in heart failure hospitalizations, so not used as much anymore.
All right, so let's kind of recap everything. If we're talking about the stages of heart failure, so at risk for heart failure. So remember, these are patients that are not symptomatic; they don't have structural disease, but they have, maybe hypertension, diabetes, cardiovascular disease, in general, whatever. We're thinking about basically just taking care of the patient's underlying diseases that could potentially push them further into having heart failure. So if we want to get optimal blood pressure control, we want to give optimal management of their CVD, whether it's with a statin or whatever else they may need. And if they have diabetes and cardiovascular disease, or even if they're just at high risk for cardiovascular disease, you could consider an Sglt2 inhibitor as well. And that might be able to kind of prolong that heart health and not allow them to kind of push to further down these stages, and then the rest of it is kind of like either whether or not you need to be screening for natriuretic peptides, biomarkers, or looking for things like that, and you also considering genetic screening and counseling as well if that's available to the patient. Yep. So stage A is more so just helping the underlying conditions. Yep. Stage B, or pre-heart failure, if the patient has a left ventricular ejection fraction of less than 40, but they don't have the structural abnormalities that are indicative of heart failure, or any other biomarkers or whatever, they recommend an ACE. And if the patient has had a recent MI and their left ejection fraction is lower, then they say an ARB if they're ACE intolerant, but they want them on one of those two. They also say to be on a beta blocker. And then, again, you can consider that genetic counseling and testing and things like that. Yep. But again, pre-heart failure means that they have one of those things that we mentioned, like whether it's structural abnormalities, but they're not having symptoms of heart failure.
Right. And when thinking about optimizing blood pressure for those patients, the guideline, I believe this was an update as well, kind of similar to some other guidelines we've seen in the last couple of years as well. Even though when you're getting patients on these guideline-based therapies, you're not, it's not because of a target blood pressure like when we're treating blood pressure. But in a patient who has stage A and we're trying to optimize their blood pressure, there is kind of a goal that they recommend with a high level of evidence, less than 130/80. So that's based on randomized controlled trial data, but they do give that recommendation, which fits along with some other guidelines that we have as well.
Yep. All right. So now if we have actual symptomatic heart failure, so stage C, and then we're gonna look at specifically HFrEF, so the reduced ejection fraction and their stage C, so they actually have full-on heart failure with symptoms and all that. We want to have, just like Cole said, an ACE, ARB, or ARNI, and then we want to do a beta blocker. We want to do a mineral or a aldosterone receptor antagonist, so spironolactone or eplerenone. We want to have an Sglt2 inhibitor. And we want to have as needed diuretics, if not, or in a loop diuretic specifically, if not scheduled. So all of those agents, so all 5 of those classes need to be utilized before moving on. Obviously, we may not be able to start all 5 at once, but those are all considered to be like first line options now. Now, if at that point, if they are still symptomatic and they're on all those meds, their ejection fraction is still less than 40, in African American patients, you can consider Bidil. And then you could also look at some of the coronary, mechanical type issues or rehab issues that you could send them to a center for. We won't go into that stuff. And then also the additional therapies such as the ivabradines and the variciguats, if they're still having hospitalizations, that's when we would need to potentially consider those. If it's refractory from that, we need to look at either doing some kind of a implantable device possibly, or a transplant rather, and even palliative care if they wouldn't be a candidate for a transplant. But that's worst case that they're, you're sending them at this point, to a specialty heart failure clinic or rehab facility that can hopefully help prolong their life as much as possible.
Right. And
yeah,
go ahead.
I was just going to say, we can touch on the additional therapies. They give some guidance on when to pick what.
Yeah, I was just going to say that they give a little guidance to say that it's probably best to try to continue to titrate and optimize these doses every 1 to 2 weeks if possible, and then that would bring you to some of the other last line options that we talked about of Aberdeen, vericiguat, digoxin. And then they also touch on lifestyle recommendations. So they recommend avoiding excessive sodium intake. That's reasonable. Not the highest level of evidence, but they said that is reasonable. If possible, with a high level of evidence, participate in exercise to improve functional status, exercise performance, and quality of life. Also, cardiac rehab can also be beneficial for these patients as well.
Mm-hmm. All right. So since we're running out of time, I will just mention the treatments that are recommended for patients that have HFMREF, or 41 to 49% ejection fraction. They still recommend diuretics as needed, so the loops. And then the first line agent with the best quality evidence is actually an Sglt2 inhibitor for these patients, which is kind of interesting. Then we have the ACE-Arb or ARNI, based on some other data, the ARNI with like some of the paragons and some of the other newer data. Then they have spironolactone or eplerenone as another option, and then an evidence-based beta blocker that we typically use for HFrEF. But the Sglt2 inhibitor would be the most important one to have on board. It's not like they're not all equal like they are with HFrEF. So Sglt2 inhibitor actually has the best data in this group.
I believe that cardiologist that came on basically said if he has a symptomatic patient with HFMREF, they're in that range, that he was starting them on an Sglt2 inhibitor. And
it's a lot easier to get them approved now as well.
Yeah, especially with this guideline update.
Yeah.
You should be able to justify that for sure.
If they have if they have improved ejection fraction, we're just continuing the original treatment that they were using with HFrEF so that we don't let them slide backwards. It's going to be important to get, that's the whole point of them even making this a separate classification.
Right.
And then you want to just touch on HFpEF real quick? Or?
Yeah, we can glance on it in the last couple of minutes if you like.
Yeah, go for it.
Only to say that there is some more evidence than we used to have. I would say beneficial evidence with using some treatments and preserved ejection fraction. So trials using comparable and efficacious agents for HFrEF have not really shown the promise in HFpEF that they have in the past. Most of the recommended therapies are directed at symptoms, especially comorbidities. So they frequently are talking about optimizing comorbidities and risk factors that might worsen it. Blood pressure control with existing hypertension guidelines is generally the most important thing. But similar to the HFMREF, if they're symptomatic and their ejection fraction is greater than 50%, they give a similar level of recommendation for the Sglt2 inhibitors. So diuretics as needed is fine, just like it has been, but they give a similar level of recommendation for Sglt2 inhibitors, and they don't for the other ones. They're there, but it is a lower level of recommendation, which is another significant update.
But what's interesting too is, so if you are looking at their little breakdown, they have an ARNI listed as a potential option. That was based on like the Paragon HF trial, noting that the patients who the lower the ejection fraction is towards moving towards that middle ground or even reduced, those are the ones that are going to have the most benefit with Entresto. And then they also mentioned aldosterone antagonists, specifically spironolactone is the one that was studied in TopCat. And that study looked promising. However, it did not meet the statistical significance for reducing mortality. There was a post hoc analysis, though, that basically showed efficacy in American patients, but not in the Russian, Georgian, or patients from Georgia. I guess Georginian. How do you say that?
Well, down in the south, it's Georgian.
Okay, but patients from the country, Georgia. In fact, they did a sample of those patients and looked and basically found undetectable levels of spironolactone. So it's like kind of interesting to see if they were even
what adherence is like.
Yeah. And so they do still mention that, but we don't have the data to back up the mortality, but it is something that can reduce hospitalizations. Now, one thing I think was interesting too is they don't actually mention ACEs. They mention Arbs because
how weird, huh?
Of the Charm Preserve trial. So if you wanted to really be evidence-based, you could do candesartan.
Yep.
And that's the one that actually has some data in Preserved, but it's still hospitalizations. It's not really mortality.
Yeah. And then I don't think I mentioned the name of the trial with the Sglt2 inhibitors, but the one to check out, which is more recent, is the Emperor Preserve trial.
Yeah.
There was a 21% reduction in the primary composite of heart failure hospitalization and cardiovascular death, driven mostly by heart failure hospitalization. So not mortality data, but still better than a lot of the stuff we have with Yeah, Georgia, they're Georgians. Do you know what you are for South Carolina?
South Carolinian.
South Carolinian.
That's
proud of it.
Are we? It sure is hot here.
It is hot here.
But,
especially under these lights, my goodness.
Yeah. AJ, what do we miss?
Got to stop drinking a gallon of water a day. It's definitely big.
You know, there's
stop drinking or start.
Stop.
There's this whole subculture on YouTube of water drinkers.
That's a subculture.
Check it out. They just videotape themselves like kind of chugging water.
Man.
Yeah, and it's led by like this one guy who drinks a whole lot of water, and they've got this big glass and it's labeled like cold drinking water, and he just downs a thing of water and he's like, stay hydrated, and they go off and there's like all these videos of people doing that.
I got to tap into that.
I
wonder if he's got heart failure.
Well, maybe one day.
You don't want to overhydrate with heart failure.
You sure don't.
So
can you imagine like that's your business plan to make a successful YouTube channel? Meanwhile, we're sitting here trying our best.
They're just drinking water.
And they're just drinking water. Who knew?
Cold drinking water.
Yeah. It should have really, maybe, I don't know. Maybe we're just not that good.
But they down it. They're not sipping on the water.
But
like,
still.
It's like.
I'm also concerned. How many of these videos have you watched?
A few.
Okay, right on.
I mean, I am.
Obi-Wan Kenobi's out now, right? Like, so I feel like that's got to be better than watching that.
I watched it last night.
Okay,
episode was only 39 minutes, which was disappointing, but good episode.
Yeah.
I won't give any spoilers. Yeah, I'm pretty much chronically dehydrated.
All right, that's good. Well, you get the tiniest water bottle of all time there.
Yeah, people who are watching can see it. Yeah,
it's a fun-sized water bottle.
I'm terrible at drinking water. I'm pretty good about it at work, but then I go home and drink. I go home at like 5:30 and do not drink water until bed, and I realize I'm dehydrated, and I chug water before bed.
It's too late.
And then I wake up in the middle of the night having to go to the bathroom. Every night I do the same. You know what the definition of insanity is?
That.
Yeah.
Yeah. Well, you guys just keep cooling your thoughts. He's going through some stuff over here. He's having a tough time. But anyways, hope that was helpful.
We had a lot of content to get through, so I didn't get to mess around. So I had to wait.
That was good. We actually stayed pretty focused that time.
We were on task tonight.
On such task. So that's good. We had to save it all for the end. So you guys, there you go. We can do it when we put our minds to it. But for those of you, again, make sure you check out the show notes, because in the link you can follow that to freeCE.com. Use the password HEART, and then do the 10-question quiz, get your credit. Don't forget, also check out our sponsor, Pearls. Download the app, pearls.com/coreconsultrx. Sign up for free. Check it out and see what you think. And then if you have any questions from Cole or myself, emails will be in the show notes, as well as like any of the social media platforms you can reach us on. And check out our Patreon as well, patreon.com/coreconsultrx, for tons and tons and tons of PowerPoint slides and lectures and all kinds of fun stuff there. So thank you guys so much for listening. We'll see you guys in the next episode. Have a great night.